So adaptive seating, when it's in use, it improves a person's posture, upright posture that is, and it can improve some functions. And we know biomechanically, because you're in a better position, it's going to create a safer swallow, and we do know biomechanically it produces better hand function. But like I said, all the evidence is very low quality, and that's really to do with cost. Like if you're a researcher and you're wanting to do a randomized controlled trial, you have to provide everyone with equipment for free. And if it's fairly intensive equipment, it can be thousands and thousands of dollars per person. So really the bottom line here is if you're going to use equipment, it has to be tailored to the individual and their environment. We're very aware there's a lot of equipment abandonment that happens when the person environment fit is not great. And importantly too, it's important to say to families that there's no carryover effects. This works while you're sitting in it, but it doesn't help somebody learn to sit. Being supported to sit is not sitting, it's supported sitting. If the person is capable of learning to sit, this is probably too much support for them. They should be practicing active practice of sitting. So we want to say here that it's really important for someone that's reached the plateauing point if their gross motor curve, no more motor function is really possible for them. But for infants who are still learning to sit, Australian infants aren't born with the ability to sit, and I'm going to assume that's the same in the UK. You want to use it sparingly, particularly if the person has a Hammersmith score over 40, but still in the abnormal range. They are going to walk, so they are going to sit. And those children really don't need a full equipment. But if their Hammersmith score is below 40, then adaptive seating can be really, really helpful for them to have full inclusion. Next slide. Ankle foot orthoses. Sometimes I feel in Australia, the minute you've got cerebral palsy, you need an ASO is the way clinical practice sometimes rolls. And they are often used by people, but it's important to understand what they're capable of doing. So we do know there's data to show they improve gait, they improve balance while standing, and they can improve gross motor function. These things, however, have to be weighed up. So you have to obviously work through, are you going to have a fixed or a hinged AFO, depending on the person's ability set and their ability to transfer. And particularly too, because we talked more about infants last week, if the person's still learning to pull to stand and they're an infant, you have to sort of weigh up, is the AFO going to help or hinder? It's certainly going to give them more balance when they get into standing, but it's actually going to make it harder to practice the transfer into standing. And there's quite good data in normal children that actually wearing no shoes gives better foot contact off the floor. And so you sort of weigh that up in infants. Next slide. So let's have a look at which interventions we've got available for prevention of contracture and what the data around them is. Next slide. So we moved over onto this column now. There's a couple of green bubbles there and a lot of yellow bubbles, most of them above the worth it line. So let's unpack these. Next slide. Okay, so let's start with the green ones. We'll start with hip surveillance, which is probably the best known of them all. And very important, population level studies done in Sweden shows with moderate quality or moderate certainty that early, systematic, routine, comprehensive, multidisciplinary management of the hips can reduce the rate of hip displacement and dislocation. Doesn't fully eliminate it for everyone, particularly in GMFCS5, but it certainly reduces the number of complications. And it can reduce the amount of orthopedic surgery these people need during their childhood, which is also important for making sure they don't have to be at rehab and can be at school, for example. And on this image, I've got a photograph of the Hip Screen app. So if you're not familiar with that, it's an app in the App Store. It's not something I wrote, but it's a great app that allows you to hover over an X-ray and calculate the migration percentages, etc., and keeps some information about the family and be able to explain to them what your steps might be. Next slide. Scoliosis surgery, of course, for people with severe scoliosis, and this can happen at all GMFCS levels, but it's much more likely at GMFCS 4 and 5. And of course, when the cob angle is over 50 degrees, we do see that people can get pressure marks. The rib margin can touch the pelvic margin, and they can get skin breakdown in the space in there. They can also get pressure marks on the back. And so this is really what we call salvage surgery, or what the orthopedic surgeons call it. It's necessary for people where their breathing's compromised or their skin breakdown. But obviously you want to think about the other things that might prevent you getting to here. But for some people, there's a genetic component to this. But certainly windswept hips also elevates the risk for scoliosis, and it's something you might think about in your seating systems. Next slide. So now let's unpack the yellow ones. So non-functional hand splints, so like a resting hand splint as shown in this picture here, they are to be worn overnight, not during the day, because you want the hands available to make contact with objects. They may have a small benefit to hand function, although I'd have to say that that data is very low quality and there's not a lot of certainty about that finding. But the bottom line is you've got to balance the potential benefits with the potential adverse events. So even though you can make a beautiful splint and it doesn't give pressure marks, they are still uncomfortable. They still tend to interfere with sleep. And you have to weigh those up. There isn't great evidence to say they definitely prevent contracture. So if they're interfering with sleep, you have to think about all the other downstream effects that might have on a person's general health, on their cognition, on their behaviour. And so those things have to be weighed up pretty carefully. Next slide. So serial casting as a way to improve range of motion, passive range of motion, and it can be used to improve gait accuracy because of better range at the ankle. We know that serial casting can be helpful. These days we know it's less painful for the person if you do it at the same time as botulinum toxin injections, and you may also get a bigger result because there's less resistance happening in the muscle to the stretch. It's a conservative management technique. It's useful for new contractures. If somebody says to me, oh no, the arm's been like that for a long time, then I'm not sure I'd really start with casting because it's fairly tough going and uncomfortable for the person. So in those cases where it's long-standing, you want to refer to an orthopedic surgeon. But again, even if you're doing this short-term, you want to balance up the benefits of pain and sleep disturbance. Some children really benefit from pain management while they're using these. Next slide. So standing frames, they can assist with improvement of range of motion, probably help bone mineral density, and they certainly seem to help social interaction because you're suddenly at eye level with other people. And many parents report that one of their favourite benefits of standing frames is the relief of constipation, and that can be very important for people that have low mobility in the upright position. So again, the quality's low. These are expensive studies to conduct. That really doesn't mean the products are low quality. It just means that they're expensive trials to conduct. I think also now that we talk more about seeing infants, we want to try this early only if the person again has a Hammersmith score below 40, so they're on a trajectory towards being non-ambulant. We don't want to start this in every infant because immobilization, when they're actually trying to learn to walk, if they're capable of it, is actually not going to be helpful to that person. So you've again got to weigh that up in under 2-year-olds. Next slide. Sleep positioning systems. Ideally, these positions, it's optimizing a portion of the 24-hour day to keep the person straight during the night. So it's really unknown whether contractures are prevented, even though that's the aspiration. There's certainly no data to say they help sleep in any way. We have a recommendation against the data. Probably do it if the children are over 2 years of age as part of a comprehensive management program, but there are some caveats thinking about it for under 2-year-olds, or particularly for people that can't communicate their needs. So you've got to balance. There is a risk of accidental asphyxiation lying on the back, and we know that from SIDS data that babies are less able to get help from someone, and so that's important. If the person has a lot of gastroesophageal reflux lying on their back, can actually exacerbate the reflux and make it harder, and or if they vomit and they can't clear their airway. So we have seen cases, they've been to the coroner in Australia of people, and it was determined by the coroner that the cause of death was the sleep positioning systems. So I think they definitely help prevent postural posture happening around the clock from that point of view. So you've got the musculoskeletal potential benefits with these safety things, and they both just need to be weighed up. Next slide. So spinal bracing, we talked about spinal surgery before. A conservative before that step might be bracing. They might reduce the cob angle. They can help with pelvic obliquity when they're being worn. And again, however, you have to balance up the harms, including making dressing more difficult. And that can be a real issue for dignity, for children who are fully included at school. Actually getting in and out of their sports uniform, for example, might be really difficult. So it's something, or going to the bathroom, it's something you have to weigh up as well. Next slide. Passive range of motion, where the therapist moves the joints through their full range of motion. Usually you will see an immediate, what appears to be a shift in the person's spasticity. However, what we're really doing is modulating the stretch reflex. And so the limb does look temporarily more loose. However, there is no carryover from this, because remember that the treatment is local to the limb and the message is central. It's coming from the brain. You've done nothing to stop that message coming from the brain. You've just released some tension in the muscles in that particular moment. There are certainly a number of other interventions that produce much better gains for reduction in spasticity. For example, spasticity medications. Next slide. Stretching, manual stretching by the therapist. Again, a very similar type of mechanism of action. Often therapists who do this a lot would say, well, I see a benefit. Well, you do see a benefit immediately, again, because you're modifying the stretch reflex. The limb does feel looser immediately. But again, there's no carryover effect from this. And you have to balance up benefits and harms with this intervention as well. So for some children, this is extremely painful. Some people are more receptive or have different pain tolerance. Also, it can be really difficult for some parent-child relationships if the parent is trying to scaffold the child's support, make them feel confident, included, and yet has to conduct something that causes pain. It's a source of tension between parents and children. There's no real data to suggest that this has any carryover effect to the desire of preventing contracture. Actually, that mostly comes from movement, not from stretching. So for me, it's one of those things. I don't use this intervention based on the data and the difficulty of the setup between parents and children, but I know it's very commonly used. But the dose, if you're going to do it, actually neuroscience suggests it needs to be 6 hours out of 24. And I don't know a lot of kids that like to lie still, or a lot of parents that have 6 hours available to them. So 10 minutes of stretching is really not going to help for the long term. So I would think if you needed that 6 hours, I'd be going to equipment that would give you a better chance of achieving that dose. Next slide. Okay, I want to sort of point this out before we go to the questions. In contrast to that evidence, and I've talked about this at the beginning, that the setup is that the highest chance of preventing musculoskeletal deformity is actually to move. If you're in equipment, you can make small movements that the equipment allows, but you don't make big movements. And so obviously these are paired around a program to allow for movement within a 24-hour period. But what actually produces function and participation, which is the goal that we said most parents and people with cerebral palsy want to focus on. Next slide. So this comes from our International Clinical Practice Guideline that reviewed all of the evidence. It's a 60-page appendix that goes with this, that goes through the data if you're a data person and like looking at that. If you're not, you can just take me, this is the summary, and have a look at it later on. There's a fair bit of data for us to work with, and we made 4 evidence-based recommendations for which interventions based on movement produce the most function and participation. Next slide. So if the person wants to work on mobility, like that top black box up there, the most effective intervention is overground walking. Now that comes as a bit of a surprise often to parents who start thinking about robotics and all these other ways they might do walking, but overground walking is actually the most effective. It produces in children GMFCS levels 1 to 4, faster walking and longer walking, so they have better endurance for walking. It's equally effective to treadmills, but probably slightly better. And this seems obvious when we look at this dad walking with this child. This child's having to make lots of decisions. I'm not going to go in a straight line. I don't want to fall off the edge of the path here. And the dad's doing a really good job of waiting with her and letting her make those decisions. That decision making doesn't happen in a robotic device or on a treadmill in the same way. So if you're going to do this, the child must be actively walking, not being pushed around in the walker by the family, and it should be in real life environments with lots of variation. So that cognitive component of all the decision making that you have to make when you're walking is also going on for the person. It reflects a real world challenge. Next slide. Treadmill training. So certainly this with people GMFCS 1 to 3 can help them walk faster and longer. Again, if you're going to use a treadmill, the child's got to be actively walking. Now, in this situation, she's taking all the steps. Someone's got their hands on her hips, not for postural control, but to make sure she doesn't fall off the back of the treadmill, because they've actually got it inclined there to make it more difficult to increase the cadence rate. When you see they're using cognitive distraction by giving her thinking tasks so that she can actually do these many repetitions. So treadmill's great if you just can't get enough dose and you want to increase the amount of practice, but it always needs to be paired with overground walking like we saw in the last slide, because there's not as much decision making. There's decision making not to fall by the child, but not about directions, stopping and saying hello to people, thinking about traffic, etc., etc. So it's not the full task, it's part task practice, and whereas overground walking is whole task practice. Next slide. So again, if you've got a more severe physical disability, you can still get the benefit from a treadmill of taking extra steps, but you're going to need a harness, and it's going to be partial body weight support. So it's suspending you, but letting you actively take all the steps like we can see in that child there on the treadmill. And again, it produces working faster and longer. And we really want to see a setup where the child's doing the walking, not the device doing the walking, particularly when people start thinking about robotic devices as well. It can be intense, and again, it's got to be paired with real life environments and overground walking. Next slide. So for children now that have a goal around hand function, so the black box there, constraint-induced movement therapy, or CIMT, is one of the most effective interventions for children with unilateral cerebral palsy, and if their max levels 1 to 3, so they can use their hands, but they need some accommodations for speed or maybe some help with the setup a little bit, but they can use their hands. It's for use of the non-dominant hand with intensive practice. There's nothing magical about the constraint. You can use a plaster, you can use a sling, you can use a splint, you can use a sock. It doesn't matter. What the key piece of it is the intensive structured practice with the Just Right challenge with the non-dominant hand whilst the constraint's on. And that's how you get the results. Next slide. Equally effective to constraint-induced movement therapy is bimanual training. Now, bimanual training is not everything that just doesn't have a constraint involved. It's a very structured intervention. And again, it helps children with cerebral palsy max level 1 to 3 to improve use of 2 hands together, whereas the constraint was working on 1 hand. And the non-dominant hand becomes an effective helper hand. That's actually the aspiration, not equal hand function so much as an effective helper hand. It must include 2-handed toys that the therapist and the family carefully select to create this practice. So you'll see with these toys chosen here, she has to use 2 hands to make this whole thing work. It won't work one-handed. Okay, next slide. Goal-directed training helps children learn tasks that matter to them. In this situation, in the video, the boy wanted to learn to ride a bike, and you can see him having difficulty getting on and off, but practicing some of that. And that's getting on and off is often one of the goal-limiting factors with bike riding. You can see him taking some steps there and working out how to find the middle and the balance there to get his feet up. They do some variation, practicing on surfaces. That's a cricket pitch. It's fake grass, and then try it on a more difficult surface over the ground. And so when we're doing goal-directed training, we can change the environment, whereas the 2 surfaces just there, we can change something about the child, maybe knowledge about how to stay in the middle, Or we could change the task. We could change the bike even. But you'll see here in this video, it's just coming near the end. If the mum gets involved as well, and there will be crashes, error-full learning is okay, as long as you learn what you've got to do next time. And by the end of 3 days of this practice, he actually obtains fully independent bike riding. Next slide. Now I want to talk to you about the last one. Those interventions there, overground walking, treadmill training, constraint-induced movement therapy, bimanual and goal-directed, they mostly work on activities. If you want to change a person's participation, you need a participation-based therapy. So sometimes goal-directed training can be used on a participation goal. But we piloted this. This work is led by Dr. Leanne Zakrzewski at University of Queensland and is currently under review and going to be accepted for publication. We randomised 107 children to usual care versus this participation-based intervention which we devised, which was individualised. It was based on the child's participation goal. It happened in the real participation context. So here's a boy that wants to learn to play rugby and he's out on the field. It's a 12-week program and it can involve changing the environment, even the social environment, perhaps the coach's attitudes to full inclusion. It can involve practice of the skills within context, so something about the child, and it also can involve modification of the tasks. But predominantly it's about practicing these tasks inside of real life environments with the right social supports. Next slide. And what we found from the children that were in this trial, randomised to the participation intervention, they had better goal achievement, both performance and satisfaction scores. They had fewer barriers to participation because part of the intervention was to deliberately overcome those barriers, and they had greater participation frequency. So this is a really important trial, even though it probably sounds bleedingly obvious when I say it to you. It's the first time we've really had this data in a decent sized randomized controlled trial, and it shows clearly when we do the other trials showed clearly when you practice an activity, you get a gain in activity. Some people can use that in context and participation, but not necessarily. Whereas if you have a participation goal, the person has one, you really need a participation-based therapy. So this is something that will be coming out in print. That's something you can use with your clients, and all of these clients really, really enjoyed this process. Next slide. Okay, so I'm just going to summarise that ground that we've covered. So number one, postural control. Posture is an automated response to voluntary movement. So it is a little bit curious that some of the interventions available, and we didn't go through them for time today, but they're going to be in your handouts, is why do we choose this as therapists as a postural control as a target? I know why. I know the history of why it's there, but really when we think now from a neuroscience point of view, what we really want to target is movement. And we already know, we talked about movement last week, movement is more successful when the person's practicing a task that matters to them than asking them to move. So these postural control interventions, they have a place in the evidence base, but it's always come up in trials that you get a much bigger result practicing the actual task or the goal that the child wants to achieve. And it's especially true in people with GMFCS 4 and 5 with limited voluntary movement. Sometimes these people get access to these same postural control interventions that we didn't cover, but they get access to a lot of these thinking, well, it's their human right to experience the chance to try and learn to move. But it really doesn't make a lot of sense actually practicing movements that they could use, maybe a head switch, like this boy, or driving a power chair would actually lead to a lot more participation and inclusion than working down at the body structures level trying to improve their posture, which is really an artifact of low movement. Next slide. So, fact for children GMFCS 1 to 3, when we're thinking about movement, postural control interventions, they are a lot of them around, and that's the section of the slide. The ones with the largest effects also train movements within the function, such as sitting or grasp, but they're things that the child uses throughout tasks. And these movements don't automatically translate to gains in activities and participation. So my style is always to ask the person and the child specifically when they're able to answer, or the adult, what it is that they would like to learn to do, because that's going to produce a bigger result than training these underlying postures. Next slide. Now, if we start thinking about these, comparing them to what we knew from the other traffic lights paper, there is a wad on the right-hand side there of things that train functional activities or task-specific performance. And so really for me, on balance, okay, hippotherapy is the one green one there. But I think this is sort of a little bit of secret sauce to hippotherapy, in that the joy of actually learning to ride a horse actually assists the person to practice all that postural control within the activity. Whereas these other ones on the right-hand side in the traffic light paper are actually around tasks that matter to the person. So on balance, you're always going to get a bigger result from those other things. Next slide. So now we're talking about postural management, which is predominantly what we covered today, that complication prevention and minimisation is possible from active surveillance. So we know this from beautiful full population, full country studies in the Nordic regions. It doesn't mean if you're GMFCS5 we're going to prevent every complication, but we can certainly prevent the timing of the onset and the severity of those complications. And the things that are the best in our toolkit are hip surveillance and scoliosis surgery, the things that when they're indicated, and hip surveillance is really important for everyone, GMFCS2 and 2 to 5, as well as GMFCS1 if they're gauge 4 on the gait. And what it might mean is less pain for these people later on and less invasive surgery. And those are all really important to supporting inclusion. We know that people with cerebral palsy that have pain generally report lower quality of life than people with cerebral palsy who don't have pain. So these are worthy targets, but we also want to think judiciously about the evidence. Next slide. And another thing about postural management, and I'm really going to finish up here, is that being straighter doesn't automatically lead to a change in your activities in participation. And so it's really important that we listen to people's goals and we jointly problem solve the barriers to their activities and participation, as well as aiming to keep them straight and prevent pain. Thank you. Is that the last slide there, Karen? Yeah, great. Thank you so much. And I think we're going to open it up for some questions. And I've left a bit more time this week.
Brilliant. Thank you very much, Iona. That was an incredible presentation. Again, I think you probably will get quite a lot of questions. We've had a couple come through already. But yeah, it's really stimulating. And there's definitely some questions from myself if we do have a delay as well. So just bear with me 1 second. I'm just going to come to the questions. So we have a question from Eve, who has recently been asked by by a child to add knee blocks to a chair by a consultant, and she's just wanting to know if there's any more specific evidence about the use of knee blocks. She has concerns about using knee blocks, but was just wondering if you have any more advice or evidence regarding them.
Yeah, it's a great question, and it's a complex one, isn't it? I mean, I think certainly having a counter force at the pelvis, biomechanically, like with the right kind of pelvic strap or bars, is really important to keeping someone. If you're having to apply another counter force on the front of the knees, I think you want to ask yourself why there's a problem at the knees. Is it short hamstrings pulling the person to have their legs straighter? Is it a position they prefer to have? Are the foot plates uncomfortable to them? Is it a movement they're making? I think placing pressure over the knees, you want to think about the location of it. So you obviously want it under the patella so that you don't create any pain. But Kieran's a physio as well. I'm an OT by background. If you want to add more to that, go ahead. But I think you want to think carefully about the place, but also think about once you put it under the patella and below the knee, then you're actually applying a force on the lower shank, not actually back through the femur to push the person back into the chair. So you've got to sort of unpack the biomechanics of that solution. So I always try and get there without knee blocks, is my personal honest opinion for a chair. If it's in standing, then of course it's completely different. We have to apply a counter force somewhere near the knee joint.
Thanks, Iona. And I think to kind of add to that from a manufacturer perspective, we've kind of shifted away from knee blocks, particularly in adaptive indoor seating in recent years for similar concerns. And it's about the concerns around pressure, and also there's many reasons as to why the position might be changing in the chair. And obviously, Eve, I don't know exactly the needs of the child, but there's many things to be looking at. Obviously, the appropriate pelvic belt, the positioning of the pelvis, the contouring and ramping of the seat. If it is that they've got quite high tone or dystonia as well, it's also looking about movement within the chair, a dynamic back. Are they pushing off the back and actually sliding forward? I personally, again, I agree with Iona and yourself in terms of reservations. There's many other options to try and explore first before something that's potentially locking down the lower limbs. If that's okay, Iona.
Absolutely, it's good. That's why I threw to you.
Just for everyone, we are getting questions through the chat, but just in case, because I didn't explain at the start, there is a Q&A tab for everybody that's dialed in. So that's where you can pop your questions. It's not the traditional chat function. So if you just have a look at the top of the screen, there's a Q&A tab. We have a question from Caroline now, who just wanted if you could comment on passive stretches for children where spasticity has been removed, for example, post SDR surgery. She has found passive range of movement can be gained for these children. So what would your thoughts be about that?
Oh, thanks, Caroline. That's a good question. I don't think there's a lot of data on it. So if spasticity is not driving the stiffness, something else is, then maybe musculoskeletal passive movement could be helpful for those people. Maybe they can respond to a stronger dose of stretch than they could before, because often when we're doing passive stretching, there's the spasticity component, then there's the resistance in the muscle fibers, and then there's also the active component sometimes of the child resisting the stretch as well. So sometimes when you take one of those components out, maybe a person would respond better to it. There's not a lot of data that it carries over much, but I think it's maybe something could have to do with some more research.
I think as like we discussed earlier as well, it's also not taking statements just purely at the statements, it's applying it to the child, to the individual. And obviously, as you acknowledge, that therapists will comment and seeing improvements on stretching in the acute phase in particular. It's not that you're just abolishing any sort of treatment, are you? It's what works for the child and what you're doing in context for those particular goals as well, aren't you?
Yeah, exactly. And most children, ideal candidates for SDR, won't have lots of range limitations. Spasticity will be the driving consideration. But, the indications for SDR are getting wider and wider. So, you may well see some people with range problems.
Thank you. We've got a question from Laura now, who was just wondering if you could just go over the interventions that you would recommend for spasticity a little bit more in depth.
Yeah, sure. So the interventions for spasticity, if we think back to hypertonicity having been two branches of an umbrella, one side is the negative side and one side is the positive side. So you've got too much of tone, be it spasticity or be it dystonia. And on the flip side, we've got not enough of strength or not enough of selective motor control. Therapists do their best job at treating selective motor control and treating strength. Doctors do their best work pharmacologically managing spasticity or dystonia. There are a range of class of drugs. They're in that paper. The ones that have the most efficacy. So if the situation is focal or there's a small number of muscles to treat, then botulinum toxin has had a lot of trials, over 30 randomized trials done, and has been shown to be safe and effective for reducing spasticity. There are some concerns that from some camps in the literature, but not all camps agree with the hesitation around botulinum toxin. There's also reasonable evidence for baclofen, particularly delivered via the pump methodology for children with GMFCS 4 and 5, can reduce spasticity, dystonia, particularly pain, and it's the one thing that does lead to an upstream gain in participation, particularly because it drives down the pain for the person and makes ease of caregiving, and they can have more time available. Oral baclofen is not as researched as ITB or the pump delivery, it's difficult because it has a very high side effect profile, because that's 100 times the dose when you deliver it orally to a pump. And so it's not as well researched. And then we've got other classes of drugs like diazepam and other muscle relaxants that also have reasonable evidence to say they can help reduce spasticity. But the key point of thinking is, think about the goal. If the rate limiting or the goal limiting factor is spasticity or dystonia, there are classes of pharmaceuticals that can help with that. If the rate limiting factor is selective motor control or weakness, then that's where the therapist comes in. But there is some old literature in our body of work that would suggest therapy influences tone. It doesn't influence it permanently. It might influence it in the moment by changing the stretch reflex, but it doesn't have any permanent change on tone because it's a central message.
Brilliant, thank you. We've now got a question from Helen regarding sleep systems. She said, we use sleep systems a lot in our service. Would you recommend an MDT approach? In this service, OTs lead on the assessments, but she feels we need to work more with the physios and nurses. And then there's a secondary question saying, would you also advise using these for GMFCS5 children? I'm obviously thinking it's relating to the quite alarming statement in terms of what you've experienced in Australia.
Yeah, look, there's no question. If you're in an abnormal posture and it's the same posture 24 hours of the day, breaking it up with 6 or 12 hours, depending on how long the child's in bed, in a more neutral alignment is going to stop that persistence of that posture dominating all the postures, maybe a windswept hip, for example, things like that. There's no question musculoskeletally it'll provide a breakup of the pattern that the child's in. So my concerns that I raised from the coronal inquiries are really around the safety issues, not around what the posture. And I think it's just, there are things you could do. If the person has reflux or night seizures causing vomiting and those sorts of things, then you might sort of have a little red flag and work through in the multidisciplinary team with the neurologist around the epilepsy management, or with the angle of the device. Like, does the person need to also be 30 degrees elevated so that they can clear their reflux, for example? So you have to sort of work through. So yes, I would advocate for a team approach. But also thinking with the speech pathologist, does this person have any communication systems that are available? Is there technology like an apnea mat that can go under it that could provide alarms and things like that, that would provide parents with an extra safety scenario? So I think those are things that you can go through. I'm a person of do no harm, try and do the best good you can. And this is one of these ones where you just have to balance things in a really sensible and logical way.
I think expanding on that again from a manufacturer's point of view, it's something of all the positioning systems, the overnight positioning, nighttime positioning is something where we advocate even more so an MDT approach, as Iona has highlighted. There's so many factors to consider and there's so many working parts in therapy, and you want to make sure goals are aligned within the team, what's going on through the day with occupational therapy and physiotherapy approaches might not necessarily be the same thing as what we're doing overnight. Going back to kind of your statement before regarding the sleep systems, do you think maybe it's also more of a case of how, because you've talked about the tilt and if the child's got severe reflux, is it more of a case of how the sleep systems are used rather than the sleep systems being the issue in terms of those sad cases? Like there is I personally experienced there's a very much of a focus of that gold standard posture, lying flat on the back, and it's great. We understand that is the teaching, but sometimes I feel things are taken at face value than a child who does need a really good night's sleep and factoring in all their comorbidities and needs first.
Yeah, I think that's really a good way to think about balancing it, because the children and adults that unfortunately passed away in Australia, they were all in supine, completely immobile, and they asphyxiated on either vomit or reflux, and were unable to move or communicate that they needed help from someone. So I do think you've got to think about that. Like, you could still get a neutral posture inside lying, where you could clear airways, for example. You could be elevated so that that those sorts of things don't happen as much. So I do think, yeah, that's the right thing to do, is to weigh up the comorbidities and actually say, what are the risk balance reward in this situation, and are there alternative management options?
I would say postural care is more than just kind of one posture, as Iona said. I mean, you can use postural care more than just the standard approach for it's that static perfect alignment. And I really like the quote that you don't have to be straight to be participating in an activity. That is very much our ethos here as well. What I would say for the attendees is I will include in the reference list a really interesting feasibility study from Chaley Services that came out last year, where they were looking at using sleep positioning systems and nighttime positioning for side lying and semi-prone to help with aspiration risk. And it's a really good way to think about multi-use ways for nighttime positioning. Just one more question on that, Iona, and then I will come back to the chat. Sorry, everybody. We talked about it before, but that kind of clarity with the statement on early years, and obviously there's a real emphasis on early intervention, and we know for engagement and getting used to a sleep system, the earlier you can apply it, the better. Also, in reality, quite often for these families, the equipment might come much later than 2 years. But how can we balance that? Could we say, actually, well, probably don't do it in under 2 years, but you can still maybe use it within the day where you can do more close monitoring? And obviously, if you have got an MDT around you, you could still do these things. But is that something that's feasible from your perspective?
Yeah, I think so. I mean, you don't want to put a toddler in any piece of equipment. That's the worst time, when no is their favorite word, right? So you don't want to start then on any piece of equipment with any toddler that I've ever met. But, if you want to start something early, then think through, well, these are the known risks, like all infants are pre-verbal. Could we get a neutral hip if you really feel you need to do it clinically? Could we get a neutral hip position and actually leave the upper chest free and the airways free, so that isn't a risk? So start actually breaking down the risk benefits into pieces related to that person. If you think, okay, well, I'm not sure about how this child or this family would manage that overnight, and could they do the checking and changing? Well, could we achieve some of those positions with multiple pieces of equipment during the day? So I think, thinking about the 24-hour window, it seems like an easy solution to use the night. But for some families, we know, are sleep deprived their entire life and they do 18 turns a night. And for other families, it's just not something that is really very feasible for them. So I think understanding the context as well as the person's musculoskeletal limitations and age is important.
Brilliant. Thank you. We've got a question from Emma now regarding hip surveillance and scoliosis surgery are most effective. But what's the point if nothing is done to manage these issues? Or is this included within the evidence and comes within the amber bubbles?
Yeah, great question, Emma. So hip surveillance, as defined, it's not hip intervention, it's hip surveillance, and it's hip active surveillance. So that means, first of all, measuring the hips from 12 months of age with a regular X-ray suite, and there is a set of guidelines of, depending on your GMFCS level, how often, and depending on the results, how often you should repeat them. It means also managing and measuring range of motion regularly to look for contractures and things that would elevate the risk of a hip displacement or spinal changes, and changing treatment in response. So if you were to look on the CP Up website, for example, which is the Swedish register, they've got these beautiful alarm codes, and they can tell you all the angles of range, that this one's in the green at this age, this one's in the yellow, you should think about changing the treatment, and this one's in the red and you need to really change the treatment. So it's an active, ongoing program which involves many different pieces of equipment, many opportunities to move during the day. It's not just hip surgery, etc. Once a problem has occurred, it's a range of comprehensive approaches at the right time from a whole team.
Brilliant. Thank you very much. So we've just slightly gone over time. We do have 3 more questions left. Do you have time for maybe 1 or 2 more? Is that okay? Brilliant. Bethany's just asked, she's heard mixed evidence about splinting with hands for children who have increased tone, and hands are often in clenched position. Does splinting help, or does it give them something extra to resist against? Is there any other interventions you would recommend for this in order to reduce contractures and improve hand function?
Yeah. So first of all, I mean, there was a big randomised controlled trial study done in Australia starting splinting early, and they didn't, they were a few participants, but either way, they got no result if the kids that had early splinting versus didn't. And again, it comes down to movement of the hands. I think if you can train grasp, you get away from some of these problems. Not everybody, we know you can train grasp in. There are some people that are max 5, but training grasp is a really, really important thing to actively train movement. It's a simple movement. You could use things like action observations to increase the number of repetitions where they're watching the movement as well as repeating the movement to open the hand. If the person is at risk of skin breakdown in the palmar crease, I will use a resting dorsal volar splint to open the air against the palmar crease, and I'll use that overnight to protect the skin integrity. But if the person's able to open the hand and they've actually got normal range of motion, because also remember that when spasticity is the response, the definition is to velocity dependent stretch. So that means when you're asleep, mostly you're relaxed. So you're putting it on at the time when the tone's at its lowest generally, because you're not moving that much unless you sort of thrash and you sleep. So I think you've got to kind of weigh that up, that component of it up as well. Is it if the person's already got normal range of motion, you can just check the range of motion. You don't have to put a splint on just in case they're going to lose range of motion. If they've got skin breakdown, definitely think about it. But you could also think about other interventions if you worked as part of the multidisciplinary team, say with a rehab specialist, even just a couple of botulinum toxin injections strategically placed in the hand might open the hand and reduce those risks. So I think, yeah, think about all the options available.
Okay, brilliant. I think we'll just do one more. Apologies to everyone else just in the chat. I'm just mindful of Iona's time. We just got one more question from Liesel, who has asked if there is any evidence that seating can prevent or reduce progression of scoliosis.
Great question, Liesel. We tried to look and see, and there isn't much evidence. There's hardly any evidence to suggest it improves function. There's a small number of low-quality studies, but not much to suggest it reduces prevention. However, we do know, I mean, you know, there's that old song, the head bone's connected to the knee bone, you know, that sort of, we're all connected. So if you are upright and you've got a neutral position of the hips, you've got a neutral position where the hands have the best chance of being on the tray for function, you're probably optimizing that person's musculoskeletal capacity. But it's certainly, if they've got genetic factors driving a scoliosis, which many of these children do. We now know 30% of cerebral palsy has got a genetic origin, and some of those predispose you higher to having these musculoskeletal impairments as well. It won't matter how much force you externally apply to a system to keep it straight. If you've got a genetic message coming from cell programming, there's not a lot a seat can do about that. But if it is genuinely, you know, you think about the biomechanics, you've got a windswept hip and you keep the hips more neutrally aligned, you've got a lower chance of a scoliosis. So I think you need to go through each person's history carefully and think about the different pieces, and the seat might help, but it might not for that goal. It might help for hand function though. It might help for swallowing, and that's definitely worth it.
Thank you so much, Iona. That's brilliant. I'm really sorry to other people that are putting questions in the chat at the moment. We are just coming to the end of the time. And like I say, I want to allow Iona to have a social life. It's quite late over in Sydney. So we really appreciate you sharing your knowledge, your experience, your time. These last two webinars have been incredible. I hope they've been really useful for everybody that's been attending as well. And again, just to repeat, everybody will receive the resources. We'll send the reference list and we'll send the recording in the coming weeks so you can review these webinars again. We will be moving on to my colleague Louise, who will be demonstrating the supine stander. But before we move on, I just want to say thank you, Iona. Hopefully we can do something similar again in the future. Thank you very much for sharing your time and expertise with us.
That's a pleasure. Hooroo, as we say in Australia. See you later, guys. Bye.
See you later. Okay, guys, we're just going to transition to Louise, who's going to be showing the accessories and features of the supine stander. If you just bear with us 1 minute as we just switch over to Louise.
Hi, everybody. This is the Jenx Supine 3. So we've got, this is the largest one in the range. There is a 1 and a 2 as well. It's much easier to show you on a video or a webinar than the larger sizes. Plus, I do have a little helper with me today who's going to get in it for us as well. So I needed it to be big. Probably the first thing you've noticed about Supine 3 is that it is big. It will comfortably stand a 6-foot adult, which again I will show you shortly. We do, like I said, have a size 1 and a size 2, and we are also able to reduce the height of this standing frame quite a bit as well by removing a couple of the boards from the top. So I'll just run you through some of the features on the frame, and then, like I say, we'll pop somebody in it so you can see how easy it is to use. So this is our lime colour, comes in a few other colours as well: red, blue, grey and pink. We've got it on a very stable frame on 4 swivel casters. Then you've got your PU boards stacked on top of that. So these are polyurethane, completely white clean, and I don't know if you can see on the video, but they are all numbered as well, which I'll talk about a little bit more when we're putting Seb in the frame. You've got 2 separate angle adjustable foot plates there, so they're angle adjustable and height adjustable separately, and I've got the size 4 sandals on here as well. A range of different sandal sizes and types are available. Just spinning it around a little bit to your back. This is your tray bracket. We've also got a couple of brackets on here as well for mounting harnesses. These are all adjustable for depth, width and height. Got a couple of handles on the back here for helping to maneuver the dining frame around while it's not in use. And then got your electrics on the back. So on your handset here, you've got your little buttons, your little battery indicator buttons there, so you know where you are with your battery before you put someone in the frame. There's a couple of quite cool safety features on here. So if for some reason you miss this and you don't realise that you've not quite got enough battery, if there's not enough battery in the system and to bring the frame completely upright and then completely back down again, it won't let you bring it up. So that means that all that will happen if you press any button is it will just go flat. And what that means is that you can't accidentally bring somebody up to stand in and then find that there's not enough battery in the system to lower them right the way back down again. If you do need to use it and you don't have enough battery, it will run while it's plugged in as well. So you have that option also. Okay, I think we'll just do a little bit of a camera swap now because Seb's going to jump in the standing frame for it. Right. And over it. Been working here now for 8 years, and I've only just learned that it's down for lay down, up for stand up. Changed my life. I think this is the first time I've done a demo and not pressed the wrong button the first time. So, right, I'm going to pop a couple of the brakes on. So one of the best things about supine, I think, is how easy it is to test and set up. So hopefully you'll get to see that a little bit today with the help of Seb. Usually we will be hoisting on, but Seb's going to just hop onto the frame for us. Seb is actually 6 foot, I found out today, so that demonstrates that as well. So normally we would have a hoist and slings and things here and keep that on while we do the assessment. Just for safety, we would usually probably do the hips first, but there is no right or wrong really with that. I've had children before who've been, so I've done their feet first, and it really is, as long as they're safe and they're not going to roll off, you can go whichever way with that. I'm going to do hips first. So you can see here you've got these little slots in the edge of the frame, and this is where your numbers come in as well. If you're wanting to use this frame for multi-users in an environment where you might want to change it for 2 or 3 different users, this makes it quite easy. You can write down the numbers, you know where things need to go, and with it being white clean as well, you do that. So I'm going to do looking for Seb's hips, and I'm going to slide in the supports. Put this one on first, and then I'll come around the front and over you. So you've got these. You've got a bit of adjustment in the actual support as well. So you find the right slot that you want, slide it on. You've also got a bit of angle adjustment in those as well. Once they're in position, tighten the wing knobs up underneath. Then got so we want to pull these up, over, get those on as tight as you can there, and then we're pulling outwards, tighten them in and attaching to the pads on the side here. And I just clip those together. So if we were in an assessment now, I would be thinking about removing the hoist out of the situation. We've got the hips on, Seb can't fall out of the frame. And with it being one solid base, there's no gaps for legs to fall down into or arms to fall down into. It's feels quite nice and safe to lay on. Again, doesn't matter now with what we do first. I'm going to do these. So these are the flexion knee supports. Now, they do look massive. Again, I have chosen a problem with the thing. I have chosen the larger. All right. I have chosen the larger accessories to show you for the video. And the reason that this one is so tall is because it can accommodate quite a bit of knee flexion. So I'll show you that while we're here. So again, locating the knee, tapping the pad on. Oh, look. And then what I'm going to do is I'm going to get this strap wrapped around Seb's knee there. So these are our X straps. They come in a variety of sizes. I want to get them on relatively tight, and I'll show you why in a moment. Underneath Seb's knee here, he's got a nice sort of arched foam pad. I'll show you one of those. So this is what's underneath his knee here. If Seb had got quite bad contractions, we would be able to build this up using PU pads underneath, so we can get this up higher or lower depending on where it needs to be. Once you've got the strap tight and the pad tight, and again remembering you've got angle adjustment in these pads, you can then rotate the knee using the derotational strap on this side. So I'll show you how his knee moves from this side, and then when I do the other side of the pad, I'll show you how the strap works. So I don't know if you can see on the video there how that is controlling the knee. You want to get that in the position that you require. Then again, I'll show you on the other side how that works. attach it to the side there and it'll stay. Somebody could invent silent Velcro. That would be a good addition to the product, isn't it? The strap is on, the pad is on. So what that looks like on this side is you've actually got two Velcro straps here, a black one and a grey one. And when you unpick them, if you pull in on the grey one, which is the top one, what you're actually doing is rotating the knee outwards. And then if you're pulling on the black one, which is the bottom one, you're rotating inwards. So once you've got the position you require, stick them back together, stick the strap to here, and that will hold there. And again, just a little bit on the top. So again, you've got your adjustment in your bracket here. So what I like to do with these is find the place where you want them to be, put them on so that once Seb is standing, they're at their highest, because then if gravity does drop you a little bit, you've got a little bit of adjustment in the pad there, rather than having to lay back down, take them off, put them back on again. But if I just this on here, all right. These are flexible thoracics, so they have got that nice hugging vibe to them. Exactly the same as the hips. What is that? To pull these straps up. Velcro nice and wrapped over there. And pull them outwards, tighten. Put together. And when you pull this strap together, you're going to get that hug. Okay. Go. I haven't strapped Seb's feet in, so I don't think I need to do that. But basically, we've got Velcro on the sandals here. Again, there are different sizes and different options. I'm going to bring you up now, Seb. Isn't it? So, Seb in his standing frame. As you can see, Seb is 6 foot, so he's up on the head pad here. If he was a little bit shorter, we can pop a head pad onto the frame itself in the same way that we can attach these, which actually makes the growth quite incredible in this frame, because if we take a couple of boards off that I spoke about at the beginning, we can then actually put the head pad really quite low down. That means that we can get it really sort of short for the shorter users, but it's also still quite wide, so we can accommodate scoliosis, we can accommodate the smaller stockier users. There's lots of flexibility and lots of growth in this. We can also pop one of our multi-grip headrests on the frame. So if you need a little bit more head support than these two headrests would offer, we can put the Jenx multi-grip 1, 2 or 3 on there. Option of a induction block. It slides in afterwards and tightens up. So that slides in afterwards there, and tightens up like this. So that can be easily taken off for hoisting in and out. And then that can be padded out using the same things that we use for the knee blocks. Obviously, if you've got this all set up for a user already, you wouldn't need to do that every time you get in and out of the frame. So, for example, if we were just going to take Seb out now, all we would need to do is feet, abduction block, unclip these 3 supports here, and then we can hoist straight out of the frame and then straight back into the frame again next time. I'm not going to pop this on because it's a little bit difficult, it's so tall. But you've got your harness options. This is one of the Jenx waistcoat harnesses. And they just feed in through the clips that I showed you at the beginning on the back there, and they're all adjustable. So you've got that, and then again, try and slide this in. Not sure if it's in the right position. Got a tray as well. So the tray is height adjustable, angle adjustable. Got your smooth area for suction here, so you can suction any toys or anything like that onto there. And then if you pop that off, you've got your bowl underneath. I think I've covered everything there. So thank you very much, sir. Switch back to Kieran now.
Thank you very much, Louise. So yeah, that's the supine stander. As Louise said, it's a brilliant standing frame for more complex postures. In particular, I find in my practice, it's something that works really well for those children that do have scoliotic postures. Like Louise said, often you're finding that those children are actually getting shorter and wider rather than growing taller, and it can be difficult to manage those postures with more modular systems. And I've had some really nice successes with the supine stander because it's so encompassing, and you can build the supports around the postures. You can be quite precise where you're placing the support. So it's definitely a very adaptable frame. It got really good growth, like Louise said, and it's definitely one to consider for those more complex postures. As we've shown on the slide before, you can scan a QR code in the resources that we send out to you to book an appointment with the local product advisors in the UK. And there's also a Jenx QR code as well to find out some more information about the supine or any other products. We do have 5 minutes left, so if there is any other further questions about the product or any other general questions about Jenx Jiraffe, you can pop them in the chat now, and we can finish off with 5 minutes of Q&A regarding those products as well. I'll just give it a minute or so, and if we've not got any other further questions, we can finish the webinar. Okay, nice easy Q&A session for me. That's great. Oh, there's one coming through now. Yes, so we've had a question from Emma. Do the knee blocks come for smaller sizes? So yes, they do. What Louise showed you was our biggest pads and our biggest straps. So they're the XL pads and our largest straps, but they come in a variety of sizes. So yeah, you can tailor it to much more smaller postures. I've set up a supine free myself recently with the medium pads and then the small straps as well. So you can really make it quite unique to the individual. It's not that you get a size 3 supine and you have to have all the largest sizes with it. You can really make it adaptable to the child you're prescribing for. Any further questions before we finish? Okay. Like I say, in the resources, you'll get the PDF of the presentation, you'll get the reference list, you'll get a brochure for the supine stander and a case study from Madison, which is a really nice case study to have a look at. We also have QR codes on our case studies that take you to the real life Instagram pages of the family and the children involved in our case studies. So when you get time, do read them. And yes, if you have a look into the PDF slide versions of the slides, there's QR codes there as well to scan for further information from Jiraffe or from Jenx. Thank you very much for attending today's webinar. Keep an eye out in the future. We will be doing continual webinars throughout the year. So keep an eye out for the next series, and we'll look forward to seeing you again in the future. Thank you, guys.